Okay, let's unpack this. We're talking about the things your body absolutely needs to survive, to thrive, and most critically, to avoid falling into that silent trap of anemia. This isn't just a basic health talk. This is a comprehensive deep dive into the molecular mechanics, the metabolic pathways, and the advanced pharmacology of keeping your red blood cell factory running at peak efficiency.
And our source material today is, well, it's absolute clinical gold. It gives us a really detailed map of all the necessary ingredients. Clinicians call these as a group Haematinics. And then there's the critical hormonal thermostat that dictates the overall pace of production, erythropoietin, or EPO, as most people know it.
Right. So our mission here is to give you a shortcut to being fundamentally well-informed about this entire system. We're going to trace the path from the raw material iron to the crucial maturation cofactors, which are vitamin B12 and folic acid, and then we'll wrap up with that powerful hormonal regulator, EPO.
Before we get into all that machinery, let's just establish the context a little. Haematinics are, simply put, substances required for the formation of blood. And anemia itself is a state where the oxygen-carrying capacity of the blood is compromised. It happens when the balance between red blood cell or RBC production and destruction gets disturbed.
Okay, so when we talk about using hematinics therapeutically as a treatment, what are the main scenarios we're looking at?
Well, we're generally targeting three main clinical situations.
The first one seems pretty intuitive. Anemia from blood loss, either acute or chronic. You just don't have enough building material left in the tank.
Exactly. The second scenario is really the core of what we're focusing on today, impaired RBC formation, because the body is deficient in one of those essential micronutrients, iron, B12, or folic acid.
And the third?
The third, and it's equally important, is anemia caused by bone marrow suppression or outright failure, and that's where the hormonal kickstarter, EPO, comes into play.
It's just amazing to think that humans have been trying to solve this puzzle for millennia. Before we get into all the chemical precision, it's worth appreciating the historical context of the very first hematinic, iron.
Oh, the historical roots are incredibly deep. Iron has always been associated with strength. I mean, in ancient medicine, figures like Lauda were using iron preparations to treat general weakness, which we now know is almost certainly anemia.
And it was even tied to mythology, right?
It was. The element itself was associated with Mars, the Roman god of strength. And then later, much later in the 18th century, we see the real foundation of modern treatment. A physician named Blod developed the famous Blod's pill.
What was in that?
It combined ferrous sulfate and potassium carbonate. And this wasn't just some folk remedy. This really established the clinical understanding that specific iron salts could overcome the debilitating weakness of anemia.
So, humans have known for centuries that this seemingly simple metal is the key to energy and vitality. That sets a perfect stage for us to begin our deep dive. Section 1. Iron, the foundational atomic anchor of oxygen transport. Okay, here's where it gets really, really interesting. When we talk about iron, the sheer scarcity of it in the body, considering its importance, is just staggering. The total amount of iron in your entire body is only about 2.5 to 5 grams. For an average man, we're talking roughly 3.5 grams.
Right, which if you put that on a teaspoon, it wouldn't even cover the tip. It's almost nothing.
Exactly. And yet that tiny amount is absolutely critical, and its distribution is very highly prioritized by the body. I think we need to understand that breakdown to really grasp how a deficiency can impact your whole system.
We do. So let's break down that 3.5 grams. Where is it all?
Okay, so the vast majority.
The vast majority, roughly 62% of the total body iron, is functionally locked up in hemoglobin, or HB. It's doing the actual nonstop work of carrying oxygen in your circulating blood. The body prioritizes this function above everything else.
So nearly 2/3 of all your iron is busy right now, carrying oxygen. What's the next biggest chunk?
That would be your storage pool. Approximately 25% is dedicated to iron stores, and it's primarily held in these large protein complexes called ferritin. And when stores get really heavy, hemosiderin. These are the emergency reserves ready to be called up by the bone marrow when needed.
Then you have the smaller but still essential portions.
Exactly. About 7% is bound up in myoglobin inside your muscles. Myoglobin is, you can think of it as the local oxygen reserve for muscle tissue, especially during intense exercise.
And the last little bit.
The remaining 6% is categorized as parenchymal iron. This is the really critical stuff that forms components of enzymes like cytochromes, which are fundamental to cellular energy production, the electron transport chain. If you run out of the 6%, your basic cellular engine just stalls.
To put this into scale, let's look at the hemoglobin structure. Our sources tell us hemoglobin is a protoporphyrin. This is that large protein ring that cradles the iron atoms.
That protoporphyrin structure is specifically designed to hold 4 iron atoms in each molecule. The implication for blood volume is pretty intense. If we estimate the body's entire circulating blood volume contains about 15 grams of Hb per 100 milliliters of blood, that translates to only about 50 milligrams of elemental iron that's actually circulating at any given moment. That is highly active iron.
And here's the massive implication for clinical treatment that I found fascinating. If a patient is severely anemic and you want to raise their hemoglobin level by just 1 gram per deciliter, which is a relatively small bump, you need to supply about 200 milligrams of elemental iron.
That's right. It takes a huge influx of raw material to see even a marginal improvement in the blood count.
Which brings us right back to daily requirements. Given this continuous high-speed turnover, what does the body actually need every day just to maintain balance?
For an adult male, the daily requirement is surprisingly small, 0.5 to 1 milligram. But for menstruating females, that requirement often doubles to 1 to 2 milligrams per day, just to compensate for monthly blood loss.
And the requirement absolutely explodes during the later stages of pregnancy.
It jumps dramatically. We're talking 3 to 5 milligrams per day in the last 2 trimesters. The total iron needed across those final months is immense, around 700 milligrams. That has to cover the expansion of the mother's own blood volume, the supply transfer to the rapidly growing fetus, and of course, preparation for the inevitable blood loss during delivery.
So if a woman starts pregnancy with already depleted stores, she's facing a severe deficit.
A very severe deficit. It's almost impossible to catch up through diet alone at that point.
So given these requirements, where does the iron come from? We know it's diet, but not all foods are created equal here, are they?
Not at all. We classify dietary sources based on density. Rich sources would include organ meats like liver, egg yolk, oysters, dry beans, and wheat germ. Medium sources are things like fish, poultry, and general red meat. But the poor sources are things like milk and root vegetables. This is why strict vegetarian diets, unless they're very carefully supplemented, pose a higher risk for iron deficiency.
Okay, so here is the major bottleneck in the entire system, and the reason why deficiency is so endemic: absorption. The average diet contains 10 to 20 milligrams of iron, which on the surface seems like plenty to meet that 1 to 2 milligram daily need.
It seems like plenty, but the reality is that the body is extremely restrictive. Only about 5 to 10% of that dietary iron is actually absorbed, and that happens primarily in the upper part of the small intestine, the duodenum. So this means if you eat 20 milligrams of iron, you may only net 1 to 2 milligrams. It's a deliberately inefficient and very, very tightly controlled system. Hashtag tag 1.1, the complex mechanics of iron absorption.
Okay, let's delve into the mechanics, because this absorption isn't passive. It's a highly complex, chemically demanding process. And the difference between heme iron and inorganic iron is crucial here.
It's the whole game, really. Heme iron, which is the iron that's already bound inside blood or meat molecules, is far superior. It can be absorbed with up to 35% efficiency. Inorganic iron, which is what you get from plants and most supplements, averages that very low 5% absorption rate.
Why is there such a huge difference? It comes down to chemistry, doesn't it? And this sort of cellular costume change that the iron has to undergo.
That's a great way to put it. Inorganic iron is mostly present in the ferric form, that's text Fe3+, in the gut. But the main cellular uptake gate only accepts iron in the ferrous form, text $2+. So before it can even enter the cell, the text $3+ has to be reduced to text 2+ to learn.
This is where we need that gatekeeper analogy for the intestinal mucosal cell. Can you describe the two main entry doors?
Sure. For inorganic text $2+, the main door is the divalent metal transporter 1, or DMT1. This is a highly selective gate on the luminal side of the cell. Heme iron, on the other hand, gets sort of a VIP access through a separate door, the heme carrier protein 1, or HCP1. Once that heme iron is inside the cell, special enzymes break it down to release the free iron atom.
Okay, so that explains the entry. But the iron isn't done yet. It still has to exit the cell on the other side to get into the bloodstream.
Precisely. To exit the cell across the basolateral membrane, the iron uses a critical efflux transporter conferiportin, or FP. This is the single export route out of the mucosal cell and into the plasma.
This is a remarkable feat of molecular engineering. Inside the gut cell, the iron is in the ferrous, text Fe2 plus Whittier state. But the moment it passes through ferroportin and enters the plasma, it immediately undergoes another conversion.
It has to. Free Hg2+ in the plasma is highly toxic. It participates in all sorts of harmful oxidative reactions. So immediately upon exit, it's converted back to the ferric form, text Fe3+, and bound to the circulating security guard, a protein called transferrin, for safe transport throughout the body.
So it changes from ferric to ferrous to get in, and then right back to ferric to travel safely.
That's the cycle. It's all about managing toxicity.
Okay, so what are the levers we can pull to maximize this complex absorption process? What helps?
The first, and maybe the most potent, is acid. Stomach acid, HCl, favors the reduction of ferric iron, which is that necessary pre-step for absorption, through DMT1. So any condition that reduces stomach acid can really impede iron uptake.
That makes perfect sense. What about dietary helpers?
Anything that acts as a reducing agent is going to help. Ascorbic acid, vitamin C, is the most famous example. It reduces the ferric iron and helps form these absorbable temporary complexes. Similarly, some amino acids containing an SH radical can help. And, as we noted, consuming meat is beneficial, not just because of the heme iron, but also because meat consumption increases HCl secretion, which helps with the absorption of any inorganic iron you ate at the same time.
Conversely, it is absolutely essential for our listener to understand what stops this process cold, especially if you're taking an iron supplement.
This is so critical for clinical application. Any source of alkalis, like commonly used antacids, Tums, Rolaids, they will raise the pH and render the iron insoluble. They completely sabotage absorption.
But what about foods that chemically lock up the iron?
Well, we have phytates, which are common in many cereals, rice, and legumes. We also have phosphates, which are in things like egg yolk. Both of these complex the iron, forming these large, insoluble compounds that the mucosal cell just can't recognize or absorb.
And some medications do this too.
Yes, the same complexing action is seen with certain medications, most notably tetracycline antibiotics. And finally, just the general presence of other high-fiber or complex foods in the stomach tends to lower the overall bioavailability of inorganic iron. This is why supplements are so often recommended on an empty stomach, even though that can cause a lot of gastric irritation. Hashtag 1.2 the ferritin curtain and iron transport.
We've established that free iron is dangerous, so the body has to have an intricate security system to prevent too much from ever entering the circulation. This is the ferritin curtain.
The ferritin curtain is it's the regulatory masterpiece of the intestinal mucosal cell. When iron uptake is high, the body doesn't just passively absorb it all. Any excess iron that enters that mucosal cell is oxidized back to the ferric form and stored intracellularly as ferritin. This is the key. This stored iron is effectively segregated, it's trapped, it's unable to pass through ferroportin into the plasma.
So the cell literally traps the excess iron. What happens to that trapped iron then?
Well, the mucosal cells have a very short lifespan. They're constantly being shed into the gut, typically every 2 to 4 days. When the cell dies and is expelled, the ferritin that it's holding and the iron inside it is also lost from the body. This is the primary mechanism that controls how much iron gets into circulation. It's a really ingenious protective sacrifice.
That explains why the body needs such tight control. Now, if the iron does make it past the curtain, it enters the plasma, and we need our main transport vehicle, transferrin or TF.
Transferrin is the workhorse. It's a plasma glycoprotein designed to bind 2 text Fe3+ residues per molecule. Because free iron is so toxic, it catalyzes the formation of highly damaging free radicals. Transferrin has to move the iron quickly and safely.
And the recycling rate here is just astonishing. This really emphasizes the dynamic nature of blood production.
It truly does. The total amount of iron in your plasma is only about 3 milligrams, which is tiny. But that small pool is recycled 10 times every single day. That means roughly 30 milligrams of iron are shuttled around daily just to meet the high demands of the bone marrow for making red blood cells. This high turnover ensures that even though iron excretion is minimal, only 0.5 to 1 milligram daily, the body can quickly respond to the immediate needs of red cell production.
So how does transferrin actually deliver its payload to the cells that need it, like the precursors in the bone marrow?
This is the delivery system. And transferrin binds to the transferrin receptor, the TFR, which is located on the surface of target cells. The entire complex, the transferrin, the iron, and the receptor, is then pulled into the cell in a process called endocytosis. Inside the cell, where the pH is slightly acidic, the iron is released for either use, like in hemoglobin synthesis, or for storage as ferritin. And crucially, the receptor and the transferrin molecule are then recycled back to the cell surface, ready to pick up the next iron load.
What's fascinating about this is that when a cell is gearing up for rapid production, say, an erythroblast preparing to make massive amounts of hemoglobin, it simply expresses more of those transferrin receptors.
It's like putting out a bigger welcome mat to maximize iron uptake.
Exactly. It's a beautifully calibrated system that ensures the iron goes exactly where it's needed most urgently.
All this complexity, all these moving parts, it culminates in a single, very common diagnosis: iron deficiency anemia, or IDA. Despite the body's meticulous conservation efforts, IDA remains the most prevalent nutritional deficiency in the entire world.
And when IDA occurs, what's the observable effect on the red blood cells themselves? What do they look like?
They become microcytic and hypochromic. Microcytic means they're smaller than normal, and hypochromic means they're paler. That paleness reflects the failure to synthesize enough hemoglobin, which is the protein that gives blood its red color. The causes, as we touched on, range from poor diet to major chronic blood loss, gastric ulcers, heavy menstruation, or chronic parasitic infections like hookworm.
The message here is pretty clear. Prevention is always going to be better than cure. Prophylaxis is essential for vulnerable groups.
Absolutely. The iron balance is just too precarious to ignore during periods of high demand. Prophylactic iron supplementation is now standard practice for all women in late pregnancy, during infancy and early childhood, and for any patients we know have chronic, low-level bleeding conditions.
When a deficiency does progress and treatment is necessary, the default preference is always oral iron. What should the listener look for when they're faced with that dizzying array of iron salts on the pharmacy shelf?
You should ignore the fancy names and look straight at the elemental iron content. That is the only metric that really determines efficacy. We have several options listed in the sources. The industry standard is ferrous sulfate.
And why is ferrous sulfate so common?
Really, it comes down to cost and elemental density. The hydrated form contains about 20% elemental iron, and the dried form has about 32%. It is by far the cheapest and most prescribed option, often despite the fact that it tends to cause more gastric irritation than some of the alternatives.
So if cost is a concern, ferrous sulfate is the workhorse. What about the alternatives that might offer better tolerance?
Well, then we look at options like ferrous gluconate, which has a lower elemental iron content, about 12%, and ferrous fumarate, which has 33% elemental iron. Ferrous fumarate is less water-soluble than the sulfate, which is why it's often perceived as being better tolerated, although it is usually more expensive. The key trade-off is almost always cost versus the GI side effect profile.
Tell us more about carbonyl iron. It sounds like a highly engineered pharmaceutical.
It is a unique preparation. It's a highly pure, very fine metallic iron powder with particles smaller than 5 micrometers. The advantage is that its tiny size gives it an incredibly high surface area. So in the stomach's acid environment, it dissolves very gradually, leading to a smooth, slow release of text IFI 2+, that is often much better tolerated long-term than these sudden boluses of iron salts.
But the source material also highlights a significant risk with carbonyl iron.
Yes. While it's well tolerated over time, if it's acutely ingested, say a child finds and swallows a large number of tablets, it is highly toxic. It releases a massive load of free iron very rapidly, leading to the same severe poisoning risks we're about to discuss. Its bioavailability is high, about 3/4 that of ferrous sulfate, making it a potent weapon, but also a serious liability if it's misused.
Why do these oral iron preparations cause so much stomach irritation and constipation? What's the mechanism?
It relates directly to the total quantity of elemental iron that's available locally in the gut. Iron salts are astringent and they're locally irritating. When high concentrations of unabsorbed iron interact with the mucosal lining, they cause nausea, vomiting, and abdominal discomfort. Constipation in particular is very common and is believed to be a direct result of that astringent action, which leads to a hardening of the fecal matter.
So the side effects are completely dose-related. If a patient is struggling with compliance because of GI upset, what's the best strategy?
Clinicians have two main levers. First, they can initiate therapy at a much lower dose and then gradually increase it, allowing the gut to acclimatize. Second, while we know absorption is technically better on an empty stomach, if the patient can't tolerate it, we often recommend taking the supplement with meals. Yes, absorption suffers a bit, maybe it drops from 10% to 5%, but if the patient actually takes the pill, it's a net win. Hashtag tag 2.2 parenteral iron therapy injection.
Sometimes, the oral route is simply not an option, and we have to bypass the gut entirely with injected iron. This is a far more aggressive and historically a much riskier approach. Why would a clinician make that choice?
We only use parenteral iron when it's absolutely necessary due to that inherent toxicity of free iron in the bloodstream. We have about 5 key indications. First is the failure of oral iron due to either severe intolerance or noncompliance. Second is established severe malabsorption.
And what kind of clinical conditions would cause that kind of severe malabsorption?
Severe inflammatory bowel diseases, or IBD, like Crohn's disease, where the intestinal lining is just too damaged to absorb nutrients efficiently. Also, chronic inflammatory states like rheumatoid arthritis, which can impair the release of iron from storage sites.
Okay, what are the other key indications for injection?
Third would be patients with severe deficiency and chronic ongoing bleeding, where the rate of loss is constantly exceeding the rate of slow oral absorption. Fourth is noncompliance, though that's less frequent now. And the fifth, and maybe the most critical modern indication, is in chronic kidney disease, or CKD, patients who are receiving erythropoietin therapy.
Let's focus on that last point. Why does EPO therapy make oral iron unusable?
Well, when you start giving a CKD patient EPO, you're essentially hitting the bone marrow with a hormonal sledgehammer. You're demanding rapid, massive increases in red cell production. This surge in erythropoiesis creates an iron demand so high that the body cannot physically absorb enough iron through the gut fast enough, even if the patient is compliant. They need a direct, immediate delivery of iron into the plasma to keep up with that EPO-driven production line.
And because iron is so toxic, these injected doses have to be calculated with extreme precision, right? Unlike oral iron, where the ferritin curtain can handle the excess.
Absolutely. The calculation is essential to ensure we give enough to fix the anemia, but don't cause an acute overload. The typical formula for calculating the total iron required for replenishment includes not only the current deficit, but also an allowance for restoring the body's stores. It's roughly calculated as $4.04 times body weight in kilograms times the hemoglobin deficit in GDL, plus a buffer. This ensures the full dose corrects the anemia and refills that 25% storage pool.
Let's talk about the evolution of the formulations. You mentioned that iron dextrin was historically very high risk.
It was. Iron dextrin was a high molecular weight colloid. Its structure meant that the iron wasn't always very tightly bound, which could lead to the release of dangerous free iron. This was responsible for its major historical drawback: a high risk of a severe anaphylactoid reaction, which could cause vascular collapse and even death. It necessitated a slow test dose and intense monitoring, making it a very serious undertaking.
So the goal of all the newer formulations is purely about engineering the molecule to keep the iron locked up until it reaches its target cell, right?
Precisely. We want a very low release of free iron. This is why ferrous sucrose and ferrocarboxymaltose were such significant improvements. They're much better tolerated, they carry a far lower risk of anaphylaxis, and they can be given in higher total doses than iron dextrin, which speeds up the overall correction time.
But the latest advance mentioned in the source material is iron isomaltoside 1000. This seems to solve the remaining problems of safety and convenience at the same time.
Iron isomaltoside 1000 is truly state-of-the-art. It consists of iron encased in this tight matrix of isomaltoside. This matrix is engineered to be exceptionally stable, and that results in a practically non-existent release of free iron into the plasma. This dramatic reduction in free iron translates directly to a near-zero risk of acute toxicity or high-sensitivity reactions.
That's the key advantage, safety. And what does that safety allow clinicians to do in practice?
It allows them to give massive single doses. Iron isomaltoside 1000 can be infused in single doses of up to 1,500 milligrams. This means a patient can receive their entire calculated iron deficit in one single short IV administration, rather than requiring multiple clinic visits over several weeks. It is an enormous win for both patient safety and convenience.
Even with these safer engineered molecules, what are the generalized risks associated with injecting iron, both locally and systemically?
Locally, if the injection leaks outside the muscle or vein, it can cause pain and, unfortunately, permanent staining of the skin and subcutaneous tissue, a dark brown mark. If it's given intramuscularly, we must use the Z-track technique, which is where you pull the skin tight before injection to create a zigzag path. This prevents the compound from leaking back along the needle track. Systemically, patients might experience transient side effects like fever, headache, joint pains, and sometimes flushing or chest tightness, though severe anaphylaxis is now much, much rarer. Hashtag TAG 2.3 acute iron poisoning. While we use iron to save lives, we have to always respect its inherent toxicity, particularly in the context of acute poisoning.
And this remains primarily a risk for young children and infants, right? Iron tablets often look like candy, and ingesting just a small number 10 to 20 tablets or more than 60 milligrams per kilogram of elemental iron can be fatal.
The pathology is swift and it's catastrophic. The excess free iron is highly corrosive. Manifestations begin with severe vomiting, abdominal pain, hematemesis, that's blood in the vomit, and diarrhea. This can quickly progress to convulsions, severe metabolic acidosis, shock, and potentially death, sometimes within just 6 hours. The free iron causes necrosis of the stomach and gut lining, which is then followed by severe hepatic necrosis and brain damage.
It sounds like a race against time. What is the two-pronged approach to treatment?
The first goal is immediate prevention of any further absorption. This involves gastric lavage, using something like a sodium bicarbonate solution to try and render the remaining iron in the stomach insoluble. We might also give egg yolk and milk orally, which helps to complex the iron. And this is also where a crucial toxicology nugget comes in. Activated charcoal, which works for almost all poisonings, does not absorb iron. It's completely useless here.
So once you've stopped the absorption, how do you deal with the massive amount of free iron that's already coursing through the system, destroying tissues?
That requires chelation therapy. We introduce a chemical magnet, the ferrioxamine. This is a powerful iron chelating agent that's given by injection, usually intravenously for rapid systemic effect. It binds the free iron in the plasma, forming a stable, non-toxic complex called ferrioxamine that can then be safely excreted through the urine. Often it turns the urine a pink or reddish-brown color.
And the dosing needs to be aggressive, I assume.
Extremely aggressive, especially if the child is already in shock. The typical dosing is 50 millikilograms, repeated as necessary, up to a maximum of 7.5 grams per day. Ferrioxamine is an essential emergency medicine that can literally pull the iron out of the blood before it can cause permanent damage to the liver and brain.
Okay, so we've established that iron is the core structural element of the red blood cell. Now we need to transition to the two key cofactors that are required to build the entire factory, the bone marrow cells that produce the red blood cells. These are the maturation factors, vitamin B12 and folic acid.
And their shared fundamental purpose is that they are both essential for DNA synthesis. Specifically, without these two vitamins, the rapid cellular division that's required in the bone marrow just stalls. The cells try to divide, but DNA synthesis is impaired, and this leads to the formation of these large, fragile, immature precursors, which is the defining feature of megaloblastic anemia. Hashtag 3.1 vitamin B12 cobalamin.
Let's start with B12, cobalamin. We often hear of its role in energy, but its true role in blood, and critically in nerve health, is far more profound.
It serves as an essential coenzyme for DNA synthesis, certainly, but its unique role is in maintaining nerve health. A deficiency is primarily responsible for demyelination, the degradation of the protective myelin sheath around your nerve fibers. And this is the crucial distinction. This neurological damage is a specific B12 failure, and it is not reversed by folic acid therapy alone.
To appreciate why it's so necessary for DNA, we have to look at its specific metabolic functions.
B12 is the linchpin for two major metabolic pathways. First, it enables the conversion of homocysteine to methionine, and this reaction is intimately linked to folic acid metabolism, which we'll get to. Second, and this is critical for nerve integrity, B12 is required to convert methylmalonyl-CoA to succinyl-CoA.
And when that second reaction fails, what happens?
When B12 is absent, methylmalonyl-CoA accumulates. The accumulation of its breakdown product, malonic acid, is actually used by chemists as the specific marker, a chemical fingerprint of true B12 deficiency. The precise mechanism by which this leads to neurological damage is still debated, but the correlation is absolute.
Where do we obtain this complex molecule?
B12 is synthesized only by certain microorganisms. It is not made by plants or animals, so we have to acquire it from dietary sources that contain or have consumed these organisms: liver, kidney, fish, and egg yolk. The daily requirement is incredibly small, only 1 to 3 micrograms.
That requirement is tiny, but the absorption process is infamously fragile. This is the intrinsic factor, or IF, problem.
It's a chemical dance that requires a specialized chaperone. B12 cannot be passively absorbed. It requires intrinsic factor, which is a specific glycoprotein secreted by the gastric parietal cells in the stomach lining. B12 binds with IF to form the B12-IF complex. This complex then travels all the way down to the very end of the small intestine, the terminal ileum, where specific receptors recognize the IF and actively transport the B12 into the bloodstream.
So if any part of that long, delicate pathway is compromised, from the stomach acid to the IF secretion to the intestinal receptors, absorption just stops. But here's the fascinating contradiction. B12 deficiency takes years to manifest, despite how fragile the absorption is.
That is the defining feature of B12. It's stored primarily in the liver. Total body stores are enormous relative to the daily need, 3 to 5 milligrams. Since daily excretion is only about 3 to 7 micrograms, if all B12 absorption suddenly ceased, the body's internal reserves could last for 3 to 5 years before deficiency symptoms manifest.
Which means that a diagnosis of B12 deficiency often implies that the underlying problem has been destroying the absorption mechanism for a very long time.
A very long time. It's not a recent development.
So what disrupts this incredibly robust system, leading to that deficit years down the line?
The classic cause is pernicious anemia, or PA. This is a cruel autoimmune disorder. The body mistakenly generates antibodies that attack and destroy its own gastric parietal cells, the ones responsible for secreting intrinsic factor. Without IF, B12 cannot be absorbed, period. Other causes include gastric bypass surgery, which can remove the IF-producing area, Crohn's disease damaging the terminal ileum, or even intestinal parasites like tapeworms that consume the B12 before it can be absorbed.
And the manifestations are a dual threat: blood pathology and irreversible neurological damage.
Hematologically, we see megaloblastic anemia. The bone marrow is producing these large, defective, immature red cell precursors. We also see neutrophils that have hypersegmented nuclei. But the catastrophic threat is neurological, subacute combined degeneration. This involves damage to the spinal cord and peripheral nerves, causing peripheral neuritis, a loss of vibration and position sense, muscle spasticity, a severe lack of coordination known as ataxia, and eventually profound mental changes, psychosis, and dementia.
And the tragic part is that if that neurological damage goes untreated, if B12 is not supplied quickly, it is permanent.
It is the critical, irreversible outcome. This is why prompt, accurate diagnosis is absolutely paramount.
Regarding treatment, why is injection the preferred route, even if the patient can swallow pills?
Because if the patient has pernicious anemia or severe malabsorption, oral therapy is functionally useless. We have to bypass the gut. The preferred preparation is injected hydroxycobalamin. It's better than the older cyanocobalamin because it has superior protein binding and longer retention in the body, which means less frequent injections are needed. The therapeutic dose is aggressive 1 milligram intramuscularly daily until remission, followed by maintenance injections, usually monthly, for the rest of the patient's life if the absence of IF is permanent. Hashtag 3.2 folic acid, folate.
Okay, moving to the second maturation factor, folic acid, which is metabolically intertwined with B12 in the most crucial way.
Folic acid is equally essential for DNA synthesis. It's the precursor to the active form, tetrahydrofolic acid, or THFA. THFA is the universal donor and acceptor for 1-carbon fragments, which are absolutely critical for 2 key steps in DNA production: the synthesis of thymidylate and the synthesis of purines. Without THFA, DNA cannot be built.
Folate is much easier to find in the diet than B12, but its storage system is far, far weaker.
It is. It's widely found in liver, green leafy vegetables like spinach, and yeast. The daily requirement is less than 0.1 milligrams. However, unlike the B12 system that lasts for years, the folate stores in the liver about 5 to 10 milligram total deplete very rapidly. If your intake or absorption stops, deficiency manifests in only 3 to 4 months. This makes it much more common in conditions like poor diet, chronic illness, or alcoholism.
This rapid turnover, combined with the metabolic reliance on B12, gives rise to that dangerous concept we need to explore fully: the folate trap.
This is the nexus of the 2 vitamins. The folate trap occurs exclusively during a B12 deficiency. Remember, we said B12 is needed for the conversion of homocysteine to methionine. That process uses the stored form of folate, which is methyl THA, and converts it back into active THFA. If B12 is missing, that reaction is stalled.
So the folate gets chemically stuck. It's trapped.
Precisely. All the folate in the body becomes trapped as methyl THFA. It accumulates, unable to move back into the active THFA pool that's needed for DNA synthesis. The body is essentially starved of functional folate, even though the total amount might be normal or even high. This stalls DNA synthesis and causes the megaloblastic anemia.
That is an excellent explanation of why a lack of B12 looks exactly like a lack of folate at the blood level. Now, what are the common causes of folate deficiency, especially given its short storage window?
Inadequate dietary intake is paramount, particularly among the elderly or individuals with chronic alcoholism who often neglect vegetable consumption. Increased physiological demand is another major driver. Pregnancy, lactation, and periods of rapid growth dramatically increase the need.
And certain drugs can cause a deficiency directly, can't they?
Yes. Prolonged use of certain anticonvulsants can interfere with absorption. More importantly, we have the cancer and immunosuppressive drug methotrexate. Methotrexate is a classic folate antagonist because it directly inhibits the enzyme dihydrofolate reductase, or DHRase, that converts inactive folate into active THFA. It essentially starves the rapidly dividing cancer cells of the necessary DNA building blocks.
The manifestations sound familiar: megaloblastic anemia, glossitis, GI disturbances. But we must stress the unique risk associated with folate.
The unique risk is congenital. Severe maternal folate deficiency, particularly in the period around conception, is strongly linked to neural tube defects in the offspring, like spina bifida. This is why folate supplementation is routine for women planning a pregnancy. But crucially, as we've stressed, the specific neurological damage seen in B12 deficiency subacute combined degeneration does not occur in cases of pure, isolated folate deficiency.
And that leads us to the most critical clinical warning in this entire deep dive: the treatment pitfall.
This cannot be overstated. Folate therapy is fast and it's cheap, and if you give it to a patient with a B12 deficiency, it will usually correct the blood picture. The anemia resolves, the red cells look healthier, and the patient feels better. The problem is that the neurological damage caused by the lack of B12, the damage to the spinal cord, is completely independent of the anemia.
So if you treat the anemia with folate, you remove the most visible symptom that would prompt a doctor to check for B12 deficiency in the first place.
Exactly. You mask the hematological problem, leading to a kind of diagnostic complacency, while the underlying B12 deficiency continues to allow that irreversible neurological damage to silently progress. This is why clinicians must always rule out B12 deficiency before initiating folate therapy for megaloblastic anemia, or, more safely, just treat with both simultaneously until the root cause is confirmed.
That is a profound dilemma. Now, what about using folate not as a vitamin, but as an antidote against drug toxicity?
That's the role of folinic acid, which is also known as leucovorin or citravorin factor. Folinic acid is not folate itself. It is already the active coenzyme form. This is essential because it bypasses the need for the DHRase enzyme that methotrexate inhibits. It acts as an expensive rescue factor to counteract the severe toxicity of high-dose methotrexate chemotherapy, preventing catastrophic bone marrow suppression and damage to the rapidly dividing cells in the GI tract.
We cover the entire input supply chain: iron for structure, B12 and folate for cell division and DNA synthesis. Now we turn to the master regulator, the hormone that dictates the overall production volume: erythropoietin, or EPO.
Erythropoietin is a specialized signaling molecule, a CLA-glycoprotein hormone with a molecular weight of 34,000. It is predominantly produced by specialized peritubular cells in the kidney, and its primary job is to act as the body's oxygen sensor.
So the kidney is constantly monitoring the oxygen levels in the blood. If oxygen delivery drops due to anemia, low atmospheric pressure, or poor blood flow, the kidney is the first to know.
That's correct. The kidney detects hypoxia, or low oxygen. In response, it immediately boosts EPO secretion, which acts as a powerful hormonal message sent directly to the bone marrow saying, massive RBC production needed immediately.
How does EPO achieve that profound acceleration of blood production at the cellular level? What's it actually doing?
It acts directly on the progenitor cells in the bone marrow, the erythroid series cells. EPO binds to specific receptors on their surface, and this initiates a powerful intracellular signaling cascade. For the technical listener, this is the JAK-STAT pathway.
Okay, let's conversationalize that complexity. What does the JAK-STAT pathway actually do in this context?
Well, it's essentially the cellular light switch for erythropoiesis. When the EPO key turns the receptor lock, it flips that switch, telling the stem cell, stop considering other options. Start dividing now and focus entirely and rapidly on differentiation and making massive amounts of hemoglobin. It forces the cells into the red blood cell production line immediately, leading to accelerated maturation and a rapid release of new RBCs into the circulation.
And because this mechanism is so powerful, the recombinant human version of EPO-ipoetin has become a transformative therapeutic tool.
Absolutely. The primary and most common indication for epoetin is the anemia of chronic renal failure, or CKD. As kidney function declines, the peritubular cells can no longer produce adequate endogenous EPO. This leads to a severe, debilitating anemia that is completely unresponsive to normal hematinics. Supplementing the hormone directly is literally life-changing, restoring energy and vitality.
Are there other therapeutic uses outside of kidney failure?
Yes, wherever the anemia is caused by insufficient hormonal drive or by bone marrow suppression. This would include anemia in HIVs, patients being treated with zidovudine, which can suppress bone marrow function. It's also used to counteract anemia induced by certain cancer chemotherapies, which can temporarily damage the bone marrow.
I know it's also used in preoperative settings, which always raises some ethical concerns given its history in sports.
Indeed. It's used clinically to increase blood production pre-operatively for autologous transfusion. This means getting a patient to produce and bank their own blood before surgery where significant blood loss is expected. However, because of its power to rapidly increase red cell count, it is of course globally banned as a performance-enhancing drug or blood doping in sports.
When you're treating a patient with CKD, what is the target hemoglobin level and why is that target range so critical?
EPO is typically administered subcutaneously or intravenously about 1 to 3 times a week. The clinical goal is highly regulated, to raise hemoglobin levels only to the range of 10 to 11 grams per deciliter. This range is sufficient to dramatically improve the patient's quality of life, their energy, and their exercise capacity.
Why stop at 11 GDL? Why not push it higher for maximum oxygen carriage?
Because of the risk-reward ratio. As the hemoglobin concentration increases, so does the concentration of red cells, the hematocrit. Once hemoglobin levels are pushed significantly above 11 GDL, the response rate declines, and crucially, the risk of serious adverse events increases exponentially. Some large clinical trials have even shown higher mortality rates when target hemoglobin levels were pushed above 13.5 GDL.
That's a vital piece of information. It highlights that more isn't always better. Sometimes it's just more dangerous. What are the specific adverse effects related to increasing the hematocrit?
The risks all stem directly from the thickening of the blood. Increasing the number of circulating red cells raises the blood viscosity and consequently the peripheral vascular resistance. The main and most common risk is hypertension or high blood pressure, which often requires careful adjustment of antihypertensive medications. But the most serious risk is thromboembolic events, the formation of dangerous blood clots in deep veins, which can lead to strokes or heart attacks.
Given the need for frequent injections, up to 3 times a week for standard apoetin, that must pose a major inconvenience for chronically ill patients.
It absolutely does, which is what drove the development of the neurodegeneration drug darbepoetin alpha. Darbepoetin alpha is a chemically modified or hyperglycosylated preparation of EPO.
What does that technical term, hyperglycosylated, mean in practical terms for the patient?
It means that additional sugar molecules have been chemically attached to the EPO protein. This structural modification acts like a biochemical shield. It dramatically slows down the rate at which the hormone is cleared or broken down by the body. The resulting advantage is immense. Darbepoetin alpha has a much longer half-life, extending to 24 to 36 hours. This allows for far less frequent injection, typically just once a week, which dramatically improves convenience and compliance for patients who require chronic therapy. Hashtag tag outro.
We've mapped the entire path today, from that single milligram of iron we need to capture daily, through the complex metabolic pathways of B12 and folate, and culminating in the powerful, targeted hormone regulation by EPO. You now understand that the profound difference between heman and inorganic iron absorption is purely a question of chemical effort. Why the ferritin curtain exists to protect you from the oxidative toxicity of free iron, and how B12 deficiency is not just a blood problem, but a long-term neurological ticking clock.
Our deep dive into this detailed source material has really provided 4 critical takeaways that synthesize and consolidate this complex knowledge for immediate application.
Okay, number 1. Iron absorption is intensely, almost violently regulated because free iron is so toxic. The primary control is that ferritin curtain mechanism, which prevents dangerous excess by trapping iron in mucosal cells that are destined for sacrificial shedding.
Number 2. The absorption systems for all 3 hematinics are complex and they're easily derailed. Iron needs the DMT1 ferroportin pathway. B12 requires intrinsic factor, and folate needs specific active transport. When these delicate systems fail, clinicians have to turn to the engineered safety of modern injectable solutions like iron isomaltoside 1000, fundamentally bypassing that failed gut mechanism.
Number 3. The most important clinical warning we uncovered is the use of folate therapy alone for megaloblastic anemia. It functions as a pharmacological mask, effectively correcting the anemia while simultaneously allowing the underlying, irreversible B12-driven neurological damage, the subacute combined degeneration, to progress completely unchecked.
So you always have to rule out B12 deficiency first.
Always.
And finally, number 4. Erythropoietin is a powerhouse therapeutic tool, especially transformative for chronic kidney disease patients. But because it artificially thickens the blood, its use requires rigorous, careful monitoring. Clinicians have to maintain that Goldilocks zone of 10 to 11 GDL hemoglobin to maximize quality of life while minimizing the severe risks of hypertension and serious thromboembolic events.
This raises an important question for you to mull over as you wrap up this deep dive. Given that the body's iron excretion is incredibly low, only zero point 0.5 to 1 milligram daily, and that the circulating plasma iron content is recycled a staggering 10 times every single day, how does the body prevent minute imbalances in intake from accumulating into a major toxic overload over decades, beyond the short-term control offered by that shedding mucosal barrier? Think about how transfer and saturation is monitored and how the long-term massive reserves of ferritin act as that final critical safety net.
A fascinating line of inquiry that connects the microscopic gatekeepers to decades of human metabolic balance.
Thank you for providing this incredibly detailed source material for us to dive into. We hope you feel thoroughly informed on the essential ingredients of blood formation.
We'll catch you on the next deep dive.